Thank you, everyone. So today we are discussing disorder of potassium metabolism, and I hope because you know that nephrology is a very vast subject, and every day they are sending call to us for management of hyperkalemia, and sometimes patient have persistent hypokalemia. He maybe have many underlying hypomagnesemia that is leading to hypomagnesemia or hypocalcemia. So it's the basics of electrolyte balances for a nephrologist to know everything in a perfect way. Okay, so today we want to discuss this potassium from the comprehensive nephrology because most of the time we are revising this book, and I hope it will be a quick revision for us and a concept building for all of us. So do not think of the potassium as simply low potassium or the high potassium. Always we have to consider, like in case of sodium, how much total potassium is in the body. And similarly, where is the potassium located? It should be known to every one of us because serum potassium represents only a tiny fraction of total body potassium.
Okay.
So you know that typical Western diet has 70 millimole per day intake of the potassium, but you know, because nowadays we are on the junk food and most of the time our sodium is too much high. So recommended sodium intake is 88 millimole per day, and recommended potassium should be more than this sodium, that is 120 millimole per day. So uh, the potassium intake is more recommended because in DASH dietary advice to stop hypertension and all the new guidelines recommend that daily potassium intake should be more as compared to the sodium because potassium has protective effects and it is present in the different fruits, etc. So GIT is the main absorptive source of the potassium, and kidney is the major route of the potassium excretion. So potassium comes through the gut, but the kidney decides how much the potassium stays in the body. Okay, so uh, you know that only approximately 1 to 2% of the total body potassium is present extracellular. The whole almost all the potassium, other potassium, the rich source is the intracellular potassium. So there is 100 to 120 millimole per liter potassium that is present in the intracellular space. So while the extracellular serum potassium is around only 3.5 to 5.3 millimole, we are checking every day the lab, and we call it hyperkalemia when it reaches more than 5.7 at least. So body potassium, if you can in your mind, you should think that body potassium is actually a huge swimming pool. But when we take a tiny cup taken from that pool, that is actually representing the extracellular potassium. So we should be very clear that relative small movement of potassium between that intracellular and extracellular compartment can produce a large difference in the serum potassium. So we all are of the four to four different drugs that we are using in the hyperkalemia management. Especially, you know that we are using the insulin in case of DK management, and this insulin is not putting the glucose into the cell, but it is also putting the potassium from the extracellular fluid into the intracellular space. So insulin can lead to the hypokalemia. Similarly, the beta 2 agonist, we are using the salmeterol, formoterol. So these drugs can put the potassium intracellularly. Please keep your mic off. Thank you. So similarly, you know that there is a fight between hydrogen and potassium actually, according to me, because India and Pakistan has two wars. One was in 1965, another was 1971. So the first war is between hydrogen and the potassium. So the natural space of potassium is intracellular. When the hydrogen is too much high, hydrogen tries to get enter into the cell. So in severe acidosis, hydrogen gets into the cell and it removes the potassium from the cell into the extracellular space. So this is the reason in acidosis, actually, in acidosis, you know that there is a hyperkalemia because the potassium has been shifted from the intracellular space into the extracellular space. So when I will be talking about the hypokalemia, if there is a metabolic alkalosis, then the potassium is relatively sure. So potassium is relatively good in quantity, and there is alkalosis. So potassium wins and it enters into the cell. So it leads a condition of you can say the hypokalemia. So if I call for the second fight, that was second war between Pakistan and India, the war of 1971. So it is the fight between hydrogen and the calcium, and they both are trying to ride on the albumin. So if there is severe acidosis, hydrogen uh, gets the ride and calcium is free from the albumin. So free calcium increases in case of acidosis. So vice versa is for alkalosis. When there is deficiency of hydrogen and there is a metabolic alkalosis, all the calcium gets bound to the albumin. So ionized calcium is decreased in case of metabolic alkalosis. Okay, so similarly, I am telling the insulin is causing hypokalemia, beta 2 agonists, they are putting into the cell potassium, hypokalemia, alkalosis, the potassium is in par and hydrogen has in deficiency, so potassium gets entry into the cells, so it is hypokalemia and acidosis. Hydrogen enters the cells and potassium has to leave the cell. It leads to the hyperkalemia. Similarly, sometimes osmolarity can lead to the hyperkalemia. So potassium is an intracellular add, and serum potassium is a location problem before it is a quantity problem. So whenever there is a small movement of potassium from extracellular fluid into the intracellular fluid, serum potassium has to fall. Like you are giving insulin, you know that extracellular fluid gets entry into the intracellular space and it leads to a condition of hypokalemia. Similarly, when there is rhabdomyolysis or there is a tumor lysis syndrome or any crushing injury or repeated blood transfusion, then this intracellular fluid, potassium is going into the extracellular fluid and you can see that serum potassium rises. Okay. So small changes in the location has a big it changes in the serum concentration. So sodium potassium ATPase pump, you know that sodium potassium ATPase pump is the basic pump that we're studying from the first year physiology, that is sending actually three sodium uh, out and putting two potassium in. So this is maintaining the enormous intracellular potassium concentration because two potassium are getting entry into the intracellular space. So three sodium out versus two potassium in. So three sodium has to flee and two potassium enters. So this is actually keeping the concentration intracellularly too high. Okay. So because anything that is stimulating sodium potassium ATPase pump that will stimulate this channel, it will lead to the rise in intracellular potassium and it will lead to the decrease in serum potassium. So important stimulator, as I have discussed earlier, it can be insulin that is stimulating this 3 sodium 2 potassium pump. Similarly, beta 2 adrenergic stimulation, you all are aware of the ventolin or salmeterol, formoterol, endacaterol, etc. We are using in the asthma and nebulization. And similarly, the aldosterone, especially it is acting indirectly through the renal mechanism. We will explain in the next pages. So cellular potassium shifts, you can see on the right side, that can be catecholamine, that can be insulin, that can be aldosterone, the osmolality, and the exercises. So these are the redistribution mechanism. Okay. So if I tell about the beta 2 adrenergic stimulation, beta 2 agonists, they stimulate the sodium potassium ATPase activation. Potassium enters the cells and serum potassium falls. So butamol, salmeterol, albuterol, catecholamine stimulation as well. So alpha 1 stimulation tend to increase the serum potassium. So you know that catecholamine, especially epinephrine and norepinephrine, they can stimulate the alpha as well as beta. But if there is only alpha 1 stimulation, it tends to increase the serum potassium. Okay. So whenever the beta 2 is stimulated, then you know that potassium gets entry into the cell. So beta puts potassium into the cell, so it will lead to a condition of hypokalemia or potassium entry into the cell. So again, I have discussed the insulin. It is activating the sodium potassium ATPase and serum potassium decreases. Okay, if I give insulin for hyperkalemia, have I removed potassium? Anybody can tell me? Yes, Dr. Akil.
If we give insulin for hyperkalemia,
Yes, if I have given insulin for hyperkalemia, have I removed the potassium from the body or not?
the potassium will enter the cells. Only intracellular transport will occur. I didn't understand the question. What are you talking about? The insulin?
I am telling that if you have given insulin to somebody, have you removed the potassium, net potassium from the body or not?
No. Total body potassium will remain the same.
Potassium will remain the same. So you have just temporarily moved the potassium from the extracellular fluid into the intracellular fluid. So the total body potassium may still be high as case of decay, you know. So aldosterone, you all are aware of. We will study that aldosterone increases the potassium secretion in the distal nephron. You all are aware of the iliac channel. So epithelial sodium channel is absorbing the sodium and it can remove the potassium. And at the second pump, it acts on the hydrogen and potassium. When there is a too low potassium, it starts working on the hydrogen potassium pump where it will remove the hydrogen, but it will keep the potassium. So it can lead to the both conditions. One is the hypokalemia, another is the metabolic alkalosis. So when we will be studying the high yield cases like Cone syndrome or glucocorticoid remediable aldosteronism, you will see that in a Cone syndrome, when there is aldosterone renin ratio more than 20 and plasma aldosterone is more than 15, you will be facing hypertension with the metabolic alkalosis and hypokalemia. Similarly, there is a new guideline in which they say that aldosterone renin ratio will be uh, more than 50 and plasma aldosterone renin ratio will be more than 50 and the serum aldosterone level will be 8. So this is also suggestive of Cone syndrome, but every time you will be facing the hypokalemia and metabolic alkalosis. But sometimes the potassium is not clinically hypokalemia, that can be 3.8 or 4.2, but it is must that potassium will be on the lower side. It is not possible that potassium will be on the 5.8, 5.6, but it can be 3.8, 3.3, 3 or 4.4, 4.3. So it will be on the lower side at least. Okay. So next is that hyperosmolarity can also increase the serum potassium. Hyperosmolarity, you know that whenever there is a hyperosmolarity, water has to leave the cells. Especially you can see there is a severe hyperglycemia, or you have given IV IG to any patient, or you have done the hysteroscopy. So all these conditions that are leading to the hyperosmolarity. So in this case, the water has to leave the cells and it has to reach the extracellular fluid. So intracellular volume is decreased and intracellular potassium concentration has risen due to this effect of dehydration of the cells. So now if you can see that potassium gradient has been increased from the intracellular compartment as compared to the extracellular compartment due to this dehydration effect, it will lead to the potassium movement from the intracellular into the extracellular space. So serum potassium will rise in case of hyperosmolarity. Dr. Akil, can you tell me this concept again?
In case of dehydration, for example, in diabetic ketoacidosis, the potassium will move with the gradient from high concentration gradient to the lower concentration gradient. So intracellular gradient, intracellular potassium concentration is high and extracellular is low. So potassium will move from the cells to the extracellular compartment.
Yes. Uh, Actually, what is happening, because in case of hyperosmolarity in the extracellular fluid, water is coming from the intracellular space into the extracellular space. So extracellular space is getting more and more diluted, and the intracellular space is getting more and more concentrated. So potassium gradient that is a natural that has now big changes. So intracellular is too high and extracellular is too low. So it compels the potassium to come out. So it can lead to the natural hyperkalemia at the end, especially in case of mannitol or severe hyperglycemia. So thank you. So this is the actually page. If you study the comprehensive nephrology, I just elaborated the whole mechanism that are written here. So now we will be discussing this page. Okay, this figure is very useful for the visual understanding. So on the left side, you can see serum potassium decreases because potassium moves into the cell. Causes can be the insulin, it can be beta agonist, it can be alkalosis and alpha adrenergic antagonist. On the right side, the increase in serum potassium because potassium moves out of the cell. Causes can be acidosis, causes can be hyperglycemia, causes can be beta 2 blockers and alpha adrenergic agonists and increase osmolality as well as the exercise. Okay, so extracellular potassium has to be equilibrate with the intracellular potassium. So into the cells, when goes the serum potassium decreases, that can be insulin, that can be beta agonist out of the cells. Again, the same concept has been repeated. So serum potassium increases when it comes out of the cells, especially acidosis, hyperosmolarity, beta 2 blockage, and exercise. So you should be seeing the table 10.1 selected foods with high potassium. So most of the time our patient present with a Bartter syndrome or they can present with the Gittelman syndrome. In both so in this case, we have to give the high potassium diet. So you should remember the high potassium diet. And many times our CKD patients, we have to avoid them on the high potassium diet. So this table should be remembered by each nephrologist that avocado has high potassium, banana, potato, tomato paste, and raisins and sugar, etc. And ये जो नारियल का पानी है, coconut oil, it also has a huge amount of potassium. So dietary potassium become particularly important when renal excretion is impaired as case of AKI, CKD, and hyperkalemia. If any patient is taking the drugs that are leading to the hyperkalemia, that can be ACE inhibitor, ARBs, and aldosterone antagonists, as well as CNIs and trimethoprim sulfamethoxazole as well. Okay. Table 10.2 distribution of total body potassium. This table is much more important conceptually. The major body potassium, you know that muscles has 2650 millimole, liver has 250 millimole, RBC 350 millimole, plasma has only 15 millimole. So plasma potassium is only 15 millimole, while the muscle contains thousands of millimole, especially 2650. So it is elaborating that how much intracellular potassium is as compared to the extracellular potassium. So serum potassium is not equal to the total body potassium. A patient can have severe total body potassium depletion while the serum potassium is only modestly low or it can be high. You know, in decay, diabetic ketoacidosis, when the decay is developing, patient has acidosis and it is putting hydrogen into the cells and potassium is coming into the extracellular fluid. And when the kidney are working properly, they are eliminating this potassium from the kidney. So in this case, the total body potassium is low in decay, but at the same time, there is a hyperkalemia. So when we start treating the hyperkalemia of decay, when we are giving second or third fluid, we give potassium together with the insulin because many patients can die of the hypokalemia while correcting the decay with the insulin. So potassium can be low or high, but we have to keep in mind the total body potassium while treating the hypokalemia or hyperkalemia. Okay, Dr. Akil?
बिल्कुल सही.
Thank you. So till now we are almost reaching the core nephrology physiology. Uh, this is where I would tell you that the kidney handles the potassium in three broad steps. There is the filtration, there is the reabsorption, and the secretion. So you all are aware of these mechanisms. There can be filtration and the reabsorption and the secretion. Then the net effect will be. So proximal nephrons reabsorb most potassium, like everything. Usually amino acids are being absorbed, the sodium is being absorbed, the glucose is being absorbed. The one and only thing that is more and more absorbed at the loop of Henle is the magnesium. Rest of all of the things are usually absorbed, especially at the proximal converted tubule. And you know the disorder of proximal converter tubule is known as Fanconi syndrome. There are multiple causes of Fanconi syndrome that can be valproic acid, that can be outdated tetracycline, that can be cystinosis, that can be hereditary fructose intolerance, that can be tyrosinemia, that can be E phosphomide, that can be multiple myeloma. You should be very aware of these causes that lead to the global dysfunction of the proximal converter tubules that can lead to the proximal type 2 RTA along with the hypokalemia and hypocalcemia and growth retardation and the rickets. So usually the proximal nephron are kings. They are reabsorbing most potassium, but the distal nephron determines the final urinary potassium excretion. Like in a gut, the final absorption of water and net position, net shape of stool is being determined by the distal colon, sigmoid colon, and everything. Similarly, in case of nephrology, the distal segments are actually the fine tuner, so they can do the fine tuning of the urine that has to be go outside the body. Okay, so let's follow this nephron. So glomerulus, if this 100% is filtered, course, then proximal tubule is actually absorbing 65 to 70%, and 30 to 35% is remaining. So if you come to the thick ascending limb, another substantial amount is being reabsorbed. This figure can show approximately 25% absorption at the loop of Henle, and the nephron can transiently have more than 100% because potassium secretion and recycling can happen again and again. Okay, so the potassium is simply progressively reabsorbed until it is almost zero. So potassium is filtered and it is heavily reabsorbed in the proximally and extensively handled in recycled in thick ascending limb, and final secretion can be final secretion or reabsorption occur in the collecting duct. Okay. So you can say that the key transporter in the loop of Henle, you all are aware of the sodium potassium 2 chloride channel. So in loop of Henle, this is the key transporter, sodium potassium 2 chloride transporter, because you know that in case of especially Bartter syndrome, the problem is in this NKCC2 channel. So sodium potassium 2 chloride is the key channel for the absorption, for the fine handling of the thick ascending limb of loop of Henle. So why it is important? Because it transports sodium, potassium, and 2 chloride into the thick ascending cell. You can see here. So sodium, sodium, potassium, and 2 chlorides. These are being absorbed from the lumen on the leftmost side on the picture, and they are being reabsorbed into the cells of thick ascending limb of loop of Henle. So whenever you are giving the loop diuretics, especially the furosemide, bumetimide, torsemide, it will block this channel of sodium potassium 2 chloride channel. So what it will lead to? It will lead to a condition of removal of water along with the potassium wasting. So this is the reason when you are giving the furosemide, you have to monitor the hypokalemia especially. So why does potassium get recycled? Romax channel, potassium moves back into the tubular lumen. This produces a positive lumen voltage. That electrical gradient helps drive the paracellular cation reabsorption, including the calcium, magnesium. Therefore, whenever you are giving the loop diuretic, sodium potassium 2 chloride channel has decreased in activity, and it will decrease the lumen positive potential, and it will lead to increased urinary calcium and magnesium losses. So, if you are unable to understand, you can understand again that sodium, potassium 2 chloride, when these are being absorbed, they get entry into the cell. Actually, which cell? Cell of thick ascending limb of loop of Henle. So sodium is being reabsorbed, potassium and 2 chloride is being reabsorbed. But there are Romax channel. You can see here, renal outer medullary potassium channel. So what happens? This potassium again gets entry into the urinary lumen. So this is the process of secretion. So this process is potentiated in the absence of magnesium. So whenever there is no magnesium, all the potassium that is being absorbed via sodium potassium 2 chloride channel, this potassium is being wasted into the urine. So in case of hypomagnesemia, because Romax channel are open, we are facing the problem of hypokalemia because renal outer medullary potassium channels are open, that are leaky channel of potassium. But actually, what is the advantage of this channel? Why nature has put this potassium channel, leaky channel here? because this potassium when gets entry again into the lumen, because it has positive charge, and you know the calcium has positive charge, the magnesium has positive charge. So here this positive charge repels the positive charge of calcium and magnesium. Due to this repulsion effect, calcium and magnesium are absorbed paracellularly. So this is the reason in case of when the potassium is coming in, when the sodium potassium 2 chloride channel is functional, the potassium is getting entry into the cells. So I want to little bit draw here. So when this channel is active properly, this red one, when this channel is acting properly, then this potassium is coming here, and with the effect of this potassium, calcium and magnesium can get entry via paracellular pathway. So all the processes are functional. But when you close this sodium potassium 2 chloride channel, this potassium secretion is inhibited. Actually, it is leading to the inhibition of calcium and magnesium absorption. So this is the reason whenever you are giving furosemide, bumetimide, torsemide, because you are inhibiting sodium potassium 2 chloride channel, it will inhibit the potassium leakiness because no potassium is in the cellular within the cells, and no calcium and magnesium will eventually get. So actually blocking the sodium potassium 2 chloride channel will lead to a condition of hypokalcemia or increase in urinary calcium. So this is the reason whenever you are studying the nephrocalcinosis, you can find that one cause of nephrocalcinosis is this loop diuretic, especially in children. They can lead to the calcium stone and they can lead to the nephrocalcinosis because loop diuretic are actually killing the sodium potassium 2 chloride channel. They are decreasing the lumen positive potential. There is increased urinary and calcium and magnesium losses. Okay. So whenever they are blocking this sodium potassium 2 chloride pump, the second effect now, okay. So whenever they're blocking this effect, because this is a loop of Henle, this sodium is now going downstream into the distal converter tubules. So when the more and more sodium is being wasted into the urine, it will lead to a condition of dehydration. So who will compensate it? You know that distal delivery of sodium will lead to the overactivity of the inact channel, and there will be uh, the distal tubule will try to attract and capture more and more sodium. So sodium will be absorbed in the distal tubule at the expense of potassium. So it will lead to the distal potassium secretion and a net effect of hypokalemia. So I request Dr. Akil to summarize this concept because this is the big concept of the nephrology that can be asked in different exams again and again, and we can explain the Barter, we can explain the Gittelman, we can explain this loop diuretics, we can explain the nephrocalcinosis via this diagram. Yes, Dr. Akil.
Okay, when we give the loop diuretics, diuretics block the sodium potassium 2 chloride channel in the thick ascending limb, and with that absorption due to the electrical neutrality effect, the paracellular absorption of magnesium and calcium is also inhibited. So with loop diuretics, we can have hypokalemia, hypomagnesemia, and hypocalcemia, and hypercalciuria
And
also.
hypercalciuria. That's
So
very
with
good.
loop diuretics, we can find the nephrocalcinosis also. Loop diuretic as a cause of nephrocalcinosis. So when the channel is blocked, the distal delivery of the sodium is increased. So when it is increased, so that sodium is again reabsorbed through the sodium potassium ATPase pump. So when that is absorbed, so what occurs? आगे आपने क्या बताया?
It will lead to the distal tubule will try to conserve the sodium at the expense of potassium sacrifice.
Okay, so they can lead to the again potassium loss and the sodium conservation. So the patient can get dehydrated with that. Because
And
patient.
more hypokalemia. And more hypokalemia.
Okay.
Okay, so thank you very much, brother. So if you can see that which one is the most important cell for the potassium secretion, most important cell for the potassium secretion is the principal cells. I have given a mnemonic of PPE, principal cells potassium excretion. So this MCQ has been asked repeatedly. So you can write on your book PPE puppy. So principal cells are the primary cells that are responsible for potassium excretion. Okay, so three major players are there in the principal cell. Sodium potassium ATPase pump that is present on the basolateral surface. ENaC channel, you know that overactivity of ENaC can lead to the Liddle syndrome. Underactivity of ENaC can lead to the pseudohypoaldosteronism type 1. And overactivity of ENaC channel can also lead to the edema in case of nephrotic syndrome, membranous nephropathy, and minimal change disease as well, with the concept of overfill theory. And the third channel is the potassium channel, that is apical potassium secretion channel. Okay, so if you can see the cells here of the distal converter tubules, yes, here it is written. So collecting duct, intercalated cells, and collecting duct principal cells. So here you can see that principal cells, PPE principal cells, they are the prime cells that are responsible for the potassium excretion. So you can see the three channels: sodium potassium ATPase pump, three sodium absorption, and two sodium entry into the cells, and ENaC channels, epithelial sodium channels, and the potassium channels at the apical surface. So sodium enters through the ENaC channel. Sodium then gets pumped into the blood by the sodium potassium ATPase pump. So sodium gets into the ENaC channel. So if you can see that there is a lumen here, so it is the urinary space. Okay. So this sodium is actually present in the urine, and we have to absorb this sodium. So this sodium has to go into the blood. So here is the blood area. So first of all, it is in the lumen, and second, it has to come into the cells, which cell? The principal cells, and then it has to go into the blood. So if you can see that if there is a more and more sodium delivery due to any diuretics like thiazide diuretics or any diuretics, so more distal delivery of sodium will be there. So ENaC is activated here. So it is epithelial sodium channel is absorbing sodium. Sodium has entered the cells, and then this sodium potassium ATPase will help, and this sodium then actually reaches the blood. Okay, so this is the first channel here. Okay, so this sodium potassium ATPase, this pump brings the potassium into the cell. Therefore, intracellular potassium again rises. This potassium can exit into the urine through the potassium channel. So you can see the here potassium channel. So this potassium is being secreted here. That was actually came from the blood here, 3 sodium versus 2 potassium. So there are leaky potassium channels, so potassium can go into the urine. So actually, if you see this epithelial sodium channel, actually that was absorbing sodium, but here you can see the second effect, that was the release of potassium in direct way. So this is the reason you face the hypokalemia in case of Liddle syndrome, okay, where there is overactivity of epithelial sodium channel. Net effect is a hypokalemia as well, you can see here. Okay, so aldosterone, you know that aldosterone acts on the mineralocorticoid receptor. So it increases the sodium potassium ATPase as well. It increases the ENaC channel activity as well. It leads to the potassium secretion mechanism as well. So actually, all these three are usually silent or working very slowly. But when the aldosterone comes, mechanism of this increases, mechanism of this increases, and mechanism of this increases. So what will be the net effect? There will be hypertension. There will be hypernatremia, sodium on the above side, and potassium will be on the lower side. So this is actually the aldosterone is a like a catalyst here. Okay. So aldosterone lead to the increased sodium reabsorption, increased potassium secretion, and net effect of hypokalemia. So if I can tell you that aldosterone actually saves the sodium with the at the sacrifice of potassium. So now coming to the intercalated cell picture, this is in the opposite direction. Here you can see this is the intercalated cell. So they actually can save the potassium as well. So I actually call the aldosterone as a traitor. So aldosterone is enemy of potassium when there is sodium present. So in case he loves the sodium, so he tries to hug the sodium and it ignores the potassium. But potassium is second love of the aldosterone. So when there is a no sodium and potassium and hydrogen are present, it starts loving the potassium at the sacrifice of hydrogen. Okay, Dr. Akil?
Okay, good.
Okay. It is his second love. Okay. So this is cell actually showing the opposite direction. So principal cells puppy, principal cells for potassium excretion. But the intercalated cells, they are responsible for the potassium reabsorption. Okay. So intercalated cells uses hydrogen potassium ATPase. It takes potassium from the lumen and enters the cells and secretes hydrogen into the lumen. So this is a very simple diagram. You can see that potassium, because the intercalated cells here no sodium is present. So in the absence of sodium, aldosterone tries to love this potassium. So when this is present, potassium is coming into the cells, and this potassium is actually then reabsorbed into the blood area. Okay, so now he is loving the potassium at the expense of loss of hydrogen. So this hydrogen is being wasted in the urinary lumen. So it will lead to the metabolic alkalosis here in this case actually. Okay, so remember the MCQ puppy principal cells potassium excretion and intercalated cells they are actually rescuing the potassium. So intercalated cells reabsorb the potassium. So you can remember ICR intercalated reabsorb potassium ICRK. Correct. ICRK intercalated cells reabsorb the potassium. Okay, so during potassium depletion, the kidney tries to conserve the potassium. Therefore, hydrogen potassium ATPase activity increases, so potassium reabsorption. So you should know that aldosterone is a vet. There, if there is a too much potassium, it will lead to the arrhythmia and patient will die. So this is the reason that when the potassium gets too low, it starts on working on the intercalated cells and it tries to reabsorb potassium and at the expense of hydrogen. So it never allows the patient to die. तो ये बंदे को मरने भी नहीं देता और जीने भी नहीं देता. ठीक है. कभी वो काम शुरू कर देता कभी वो लेकिन एक्चुअली ये सोडियम लवर है. ओके. Okay, so next picture, next page. I am telling you the last page of today. So actually, this is the basic concept. If you will learn this page, then hypokalemia and hyperkalemia, everyone is aware of that. There are 8 to 10 causes. It is nothing to remember in hypokalemia and hyperkalemia. But actually, if you know physiology, if you know the basics, you can understand the needle, you can understand the butter and detail and everything. Okay, so what determines the potassium secretion? This page is very, very important for understanding the hypokalemia. So you can see that there are 5 things that determine the potassium secretion. Number one is the luminal flow rate. Most of the people are unaware of this mechanism, especially the newer nephrologists. Distal sodium delivery, we have discussed many times, so you are aware of it. Aldosterone, we have discussed, you are aware of it. Extracellular potassium, yes, it depends upon the serum concentration. You are aware of it. Acid-base status, I have discussed you like 1965 war between India and Pakistan. So hydrogen and potassium has a fight. So in case of acidosis, hydrogen has power and hydrogen gets entry into the cell and potassium comes into the extracellular space, leads to a condition of hyperkalemia. But in case of alkalosis, potassium goes back to its chair, its normal position, intracellular, so it can lead to the massive entry into the cell and it can lead to the alkalosis as well. Okay, so 3 big controllers, if anyone can ask, one is the urine flow rate or luminal flow rate, other is the sodium delivery, and other is the aldosterone. Okay, so Dr. Akil, इसका जो है ना, you can remember the mnemonic of दफना. ठीक है, ये अपनी बुक पे लिख दफना DFNA. सो हम जब बंदा कोई शहीद हो जाता है तो दफना देते हैं. तो DFNA, D for distal sodium delivery, F for flow rate, especially luminal flow rate, N for जो है ना वो ये है कि सोडियम डिलीवरी, डिस्टल सोडियम डिलीवरी, फ्लो रेट, और A for एसिड बेस स्टेटस, और A for aldosterone. Okay.
Okay. N for
distal
N, what is N for?
N N यार N for डिस्टल सोडियम. अच्छा,
Okay.
N for बदल के इसका कोई और बनाओ यार, कोई फ्लो रेट. हाँ, luminal flow rate, aldosterone, एसिड बेस स्टेटस, एक्स्ट्रा सेलुलर पोटेशियम एज वेल. इसको कोई और बनाना पड़ेगा, इसको देख लेना यार. और फना कह सकते हो, यू कैन से द
दफा
फना
कर दो
फ्लो
ना.
रेट.
DAFA,
Ah,
DFA.
DAFA. DFA, DAFA. D for distal sodium delivery, F for flow rate, A for aldosterone, and A for acid base status, and extracellular potassium as well. Okay, so DAFA E दफा लगाना है ठीक है E दफा इसको यार मुझे सेंड कर देना so three big controllers that can be that I told you that flow rate sodium delivery aldosterone extracellular potassium and acid base status as well. So if there is a high flow activates potassium secretion. Therefore, if there is a diuretic, they are increasing the flow rate. So distal flow is increased. So potassium secretion is increased. It can lead to the hypokalemia. You know, when there is a massive flow, potassium is just coming into the uh, proximal tubule, going to the loop of Henle, going to the DCT, and going rapidly into the collecting duct and into the urine. So when there is a flow rate, the electrolyte potential is quickly faded away. So new potassium can easily come to replenish that loss of electro voltage. Okay, so increased flow rate in case of loop diuretic, it leads to the increased potassium secretion and hypokalemia. Other is high distal sodium delivery. This is the big gun, big concept. More sodium reaches the collecting duct. Sodium enters through the iliac channel as we have discussed. So principal cells will lead to the more potassium secretion. So if there are combined loop and thyroid diuretic, more and more sodium is reaching the distal area, and in order to conserve that sodium, potassium has to give the sacrifice. So why potassium-sparing diuretic cause hyperkalemia? Drugs such as amiloride and triamterene actually they are blocking the iliac channel. So when they are blocking the iliac channel, this luminal sodium that was present here, I can show you again. This luminal sodium that was present here. Now in the presence of amiloride and triamterene, it cannot go into the cells. When it cannot go into the cells, this channel is also blocked, and this potassium is not now coming into the urine. So actually, iliac channel activity is leading to here potassium loss. So when you block this iliac channel, amiloride and triamterene, uh, they are preserving the potassium. So less sodium enters the principal cells, less lumen negative potential, and less potassium secretion. Net effect is hyperkalemia. So other is the metabolic acidosis. We have told you that acidosis always causes hyperkalemia. Mechanism I have told you again and again. So magnesium and potassium. Hypomagnesemia, I have told you that renal potassium wasting is increased and it leads to the refractory hypokalemia. So in last picture, I have told you that the Romac channel here. Okay. So these are renal outer medullary potassium channels. They remain open in the absence of magnesium. So magnesium is a teacher. If teacher is present, the student will be residing in the room. The student will be in the classroom. But when the teacher goes out, so magnesium goes out, the student gets out of the class and they are wasted. So in the absence of teacher, the students are get wasted. So loss of magnesium can lead to the loss of potassium into the urine. So hypomagnesemia can lead to the hypokalemia. Okay. So whenever there is a refractory hypokalemia and refractory hypocalcemia, there is always magnesium deficiency. Drugs associated with the hyperkalemia. Uh, Next page. So table कौन सा है 129 पे. Yes, so here you can see the drugs that are associated with the hyperkalemia that can be potassium containing drugs like KCl intake, beta blocker, propranolol, ACE inhibitor, or losartan, valsartan, direct renal inhibitor, aliskiren, and heparin, as well as CNI, so potassium sparing diuretic amiloride, triamterene, as we have discussed, and SADs because they are decreasing the prostaglandin, they are decreasing the REN and decreasing aldosterone and potassium excretion. So I hope the basic concept is clear. So we will be going to the advanced concept on the coming lecture, inshallah. Thank you very much, everyone. Any question, please? Yes, Dr. Lorena, have you got concept?
Yes, thank you very much. But the microphone was very bad, so it was very difficult to hear.
Yes, potassium is a little bit. difficult, but you should study it and listen it again. I will share you the recording, inshallah.
Okay, thank you very much.